Just a minute. Okay. Is my video on? Am I
Yes, my
visible?
video is on.
Okay, I'll
And
just share my
volume
slides.
is also clear.
Okay.
Some slides are visible.
Yeah, just 1 minute. Okay, so are we ready to begin?
Yes, ma'am. Dr. Narang, sir,
हाँ जी
shall we start?
जी सर जी मैम
Okay, okay.
So शुरू
Uh,
करें?
हाँ जी
yes,
बिल्कुल
yes, ma'am. I will introduce you properly and then.
Okay, sure.
Yeah, good afternoon, everyone. On behalf of Satluj Academy of Pediatrics, State IIP chapter of Punjab, we welcome all of you on the World Obesity Day. And today we have renowned a speaker. First is by a talk on pandemic obesity, childhood obesity, role of a pediatrician by Dr. Vandana Jain, ma'am, who is a professor in charge, pediatric endocrinology division, recipient of multiple awards, oration, more than 30 funded project under her name, and numerous chapter in the field of pediatric endocrinology. And second is Sheryl Salis, ma'am, over 25 experience in the field of dietics and type 1 education, Lancet type 1 diabetic commissioner, ISPAD uh, special interest faculty for 2025 and 26. So I welcome both of you, ma'am. And now I hand over to Dr. G.S. Narang, sir, for brief overview of the program and official start of the program. And chairperson of the day is Dr. Ravi Bansal, sir, director, Chandigarh Childcare Center, Kotkapura, having vast experience in the field of pediatric, especially neonatology, over 30-year experience. So welcome all of you on World Obesity Day from Satluj Academy of Pediatric 2026. So over to you, sir.
thank you Dr. Seema. We are very excited to have our Dr. Sheryl, who is Director, Nurture Health Solution, and Dr. Vandana Jain on this very important topic on World Obesity Day. And I also welcome Dr. Ravi Bansal, who is our close friend and senior in Kotakapura. Take more time, I want. Let's start the session. Dr. Seema, let's start.
Okay, over to you, ma'am. Vanda, ma'am, please start the session.
So a very good afternoon, everybody. And I would begin by thanking the organizers, Dr. Seema and all the other organizing team. I'm happy to speak on childhood obesity. And the topic is pandemic of childhood obesity, the role of pediatrician. So, the overview of today's presentation is that I'll briefly introduce what is obesity and specifically the difference between exogenous and non-exogenous, because as pediatricians, obviously, we should all be alert to the diagnosis of possibly non-exogenous obesity. So I'll discuss that briefly. But then the rest of the talk will be primarily on exogenous, that is the obesity caused due to energy imbalance, prevention as well as management, and some of the newer guidelines and pharmacotherapeutic therapeutic management options also we'll discuss briefly. So obesity, as we all know, it is caused by a long-term positive energy balance. So basically, it is not caused by short-term binge eating. We all love an occasional sweet or an occasional indulgence. That does not cause obesity. It is the chronic increase in energy intake as compared to energy expenditure, which leads to buildup of fat stores. So, on the surface of it, it seems like there is a simple paradigm that once we have eaten enough, there should be satiety, and then we should not eat more. So, if we look at this, very simplistic diagram, before eating, ghrelin is more. Ghrelin is the hunger hormone, which is produced by cells of the GI tract, and your leptin is low. Leptin is produced by the adipose tissue. So, when you're hungry, you have more ghrelin, you have less leptin, so there is balance towards eating. Once you've eaten, then the satiety comes in because ghrelin increases, Ghrelin decreases, the hunger hormone decreases, whereas leptin increases because this is the adipose store. So you've taken in the energy, so adipose store is full, and so leptin increases. So this is the simple thing that this should happen, but this does not happen because we actually sort of overcome the satiety cues. It's said that humans eat relentlessly. So we are tuned to this, that despite not feeling hungry, we are still eating because of various reasons, and children are also doing the same. Many times they're just eating because of boredom or because food is all the time available. Too much energy dense foods are available. So it is cue driven food seeking and consumption. Marketing is, of course, driving it, and ready availability of food. So we talk about obesogenic environment. So what is an obesogenic environment? So of course, screens, availability. These are the options which are available. If we ask a child that what would you want to eat, or what treat you want, so treat would be obviously something like that. It would not be an apple. So this is the difference between the obesogenic environment and what ideally should be. So because of this, ultimately there is something called the hedonic pathway, which is, hedonic means pleasure, that we, whatever we find pleasurable, that is there. So we want to take the easy way out. So there is constantly a sleep debt. We are sleeping less, sedentary behavior. Endocrine disruptors are also playing a role. They are all the time available in the environment. A lot of plastic usage is there. Social and economic stress also. Because of stress, sometimes we eat more. And of course, we know that healthy foods are typically more expensive as compared to energy dense, cheap foods like colas and packets of chips. They're always hanging, a lot of different varieties of cookies, cakes, and in India, of course, sweets. So ultimately, this hedonic pathway leads to the shifting of the body weight set point, and initially a temporary increase in weight, which is sustained over time. We all know, as adults, we experience this, that we have a set body weight. If we gain, we try to lose, we try to come back to what we were. And if we lose, then we try to gain. And the same thing happens in children also. They, after an illness, acute illness, they lose weight, then they actually come back to their own centile. But the opposite thing is not happening in children, that if they gain excessive weight, then they actually keep on gaining more. So this is what is happening. So the other thing is, we need to worry about obesity is because Indians are possibly at higher risk of having obesity and having more adiposity. One may be related to our diet and lifestyle, that it is a carb-centric diet, whereas if we see in Western cultures, they eat a lot of protein. Animal-based diet is very common. Right from breakfast, they would take it. But in Indian culture, even if people are non-vegetarians, they would not take it daily, or possibly even if daily, then it would be in smaller quantities. Then rapid economic transition is there. Sedentary lifestyle has come in. So we have adopted the sort of the poor behaviors from the West, unfortunately. And then our own body type is called the sarcopenic and the high fat phenotype. So less muscle, more fat. So this is like high metabolic load, but low capacity. Capacity is your muscle. And Indians, like, because they're born low birth weight, so many studies have shown that when you catch up, children born low birth weight typically catch up within the first 1 or 2 years, they, in terms of their weight and height, but it is seen that they typically sustain a deficit in the fat-free mass. What they make up for is the low fat that they were born with. Initially, it was thought that Indian babies had a thin fat phenotype right from birth, that at birth also they had more fat and less muscle, but now it is seen that it is not like that. There are several studies, including our own, where we have shown that at birth, Indian babies have lower fat mass as compared to Caucasian babies. But when during catch up, they actually gain more fat and less fat free mass. It may be related to various factors. It may be ethnic driven, genetic driven, or it may be related to our diet and lifestyle or maternal diet and lifestyle, but these are the factors that play a role. So now we'll briefly talk about diagnosis after that introduction. So first is, how do we say that yes, this child has obesity or overweight? And the second is it exogenous versus non-exogenous? So let's begin with this case. I'm showing the picture of this child and his mother. This 13-year-old boy, he presented to us with excessive weight gain over the last 5 years. There was history of obesity and type 2 diabetes in father and paternal grandmother as well. And we can see that the mother also has obesity. And the child, when we look at him, he looks like any other child that we are seeing every day. He does not clearly look obese. And it is good that he actually came with these concerns, but many children actually don't come with this concern. Many times, as many of you may have seen, and especially in pediatric endocrinology, what we see is that they come with concern of small phallus. Boys often come with concern of small phallus, and because the phallus appears to be buried in the pubic fat. And then when you point it to them that the child has obesity, then they do concede, the parents do concede that yes, obesity is an issue, but we are more worried about the phallus. Obesity is not that much of a concern. So here I'm showing the neck of the child, and you can see that there is mild acanthosis, which is clearly appreciable. So he's not a very marked case or a florid case where we see children who are already very, very heavy, weight of more than 100 kilos with very marked acanthosis, already type 2. No, he's not like that. So his height is at the 75th centile. Weight was between 90th to 97th centile, BMI of 26.5 kg per meter square. So we need to know how to interpret this. Waist circumference was 95 centimeters, BP is 126 by 88. Again, we need to know how to interpret BP in younger children. Then Tanner stage 3, and he had bilateral pseudogynecomasia. What is pseudogynecomasia? That the mother was worried about the contouring of the breast, but it was when we tried to palpate, there was no breast part, it was all due to fat. So other investigations that we did for him were, you can see that the ALT and AST are mildly raised. The normal levels of ALT and AST are somewhere around 22 to 24 units per liter, and not around 30-35, they're 20 to 22. So these are elevated. About more than 2 times the upper limit of normal ALT is considered as indicative of possible fatty liver disease, which is now known as metabolic associated steatotic liver disease, MASLD. Then we did the lipid profile. So you can see that the triglycerides are mildly elevated, total cholesterol is high, LDL is high, HDL is low. Fasting plasma glucose is 120 milligram per deciliter. What is the interpretation? It is impaired. And 2 hours OGTT is also showing 178 milligram per deciliter. This also comes as impaired glucose tolerance. This is impaired fasting glucose. Ultrasound showed that he had grade 2 fatty liver, and PSG, which is polysomnography. So this showed an AHI of 9.5. What is this? That in children with obesity, and specifically if there is a history of snoring, one should do a polysomnography. And if you find an apnea-hypopnea index which is elevated, that indicates that there is sleep apnea, most likely obstructive sleep apnea, which is common in children with obesity, and it needs to be addressed either by weight loss, or if the child is not able to attain that, then they may require CPAP, nocturnal CPAP. So I've just marked the BMI of this child, and you can see that 26.5 per se, if we compare, okay, for adults, it may not be that high. But for this child, we use the IAP 2015 BMI charts, and you can see that the lines here are 3rd, 5th, 10th, 25th, and 50th centile, and after that, there is no centile line. We have these 2 lines, which is one is equivalent to 23 kg per meter square of adult equivalent BMI, which means that a child above this line is overweight, and a line above 27 adult equivalent BMI means that the child has obesity. So this child had obesity. So what is the diagnosis of this child? This child has, sorry. So this child has generalized obesity as well as abdominal obesity, and I have written that it is class 2. So I'll discuss this a little bit more, that what are the classes of obesity, and why abdominal obesity, because the waist circumference is also elevated. So waist circumference also has an importance. He has pre-diabetes. There is insulin resistance as seen by the acanthosis nigricans, as well as the impaired fasting glucose and impaired glucose tolerance. There is dyslipidemia. There was MAFLD or MASL, metabolic syndrome, and obstructive sleep apnea. It was there. So coming to the definitions of obesity and overweight, for 0 to 5 years, we use the WHO MGRS 2006 charts. Did Dr. Seema say something? Sorry.
No, ma'am.
Okay. So for 0 to 5 years, we use the WHO charts. And here the definition of overweight is BMI or weight for length or weight for height above +2 standard deviation. So overweight is also +2. It is not +1. And for obesity, it is BMI or weight for length or height above +3. So in 0 to 5, we are basically more lenient. We are using a cutoff of more than 3 for obesity and more than +2 for overweight. And for 5 to 18 years, we can use either WHO or IAP 2015 charts. We preferably use IAP 2015 definition only. If we were to use WHO definition, then overweight here is more strict. BMI above +1, obesity is BMI above +2. When we used IAP, then actually, as I showed you, we have the BMI centile of 23 kg per meter square, and this is approximately equal to 71st centile. So much below the 85th centile. It is 71st centile or plus 0.55 standard deviation for boys, and this is equivalent to 75th centile or plus 0.67 standard deviation for girls. So remember that many of us now use Anthrocal or other calculators, and we simply calculate the SD score. So don't think that +2 is obesity or +1 is overweight. No. So using the IAP charts, plus 0.55 in boys and plus 0.67 SD in girls is overweight. And similarly, obesity comes as plus 1.33 SD for boys and plus 1.63 SD for girls. Other anthropometric measures, we use the waist circumference for age 6 to 10 years, more than 90th percentile. And there are Indian data available. Dr. Khadilkar's group has published. So we can use those references. And for 10 to 16 years, more than 90th centile or adult cutoff, which is 90 centimeters for men and 80 centimeters for women. These are ethnicity-based cutoffs. So these are for us 90 and 80. And remember that actually, although we use more than 90th centile as definition for abdominal obesity, but in Dr. Khadilkar's paper, they have pointed out that waist circumference above 70th percentile is actually a risk or is associated with higher risk of metabolic syndrome and all the complications of obesity. Then waist to height ratio. Waist circumference to height ratio is another easy to do anthropometric measurement because this is sort of age independent and easy to do. So more than 0.5 and more than 0.6 can be taken as markers of overweight and obesity. So for a child whose height is 150 centimeters, if his waist circumference is more than 75 centimeters, he has overweight. So then we talk about the classes, severe obesity in children. This how do we define severe obesity in children? So AAP, that is the American Academy of Pediatrics, had given the definition that BMI more than equal to 35 kg per meter square or more than 120% of the 95th centile for age and sex, whichever is lower. That is considered as severe obesity. For Indian children, this definition has been modified. For Indian children above 5 years of age, BMI, which is more than 120% of the IAP obesity cutoff of 27 kg per meter square adult equivalent centile, that is further classified as class 2 and class 3. Class 2 is more than 120 but less than 140% of the IAP cutoff, and class 3 is more than 140% of the IAP obesity cutoff. So basically, it is when we see an obese child, it is good to classify further whether it is class 1, 2 or 3 obesity. So let me just ask a question. Maybe the audience can answer in the chat box. An 11-year-old boy with BMI at plus 1.5 standard deviation score and height at minus 0.1 standard deviation with a mid-parental height of 164 centimeters. So the parent's chief concern is short stature and short penile length. So which of these tests will you do? And I have listed a few tests. So what are the thoughts? If people want to answer in the chat box. So
Please type
we
in
can
the chat now.
Sorry.
Uh, no, ma'am, I'm just requesting residents. Residents are there in the group. Please,
Okay.
you can directly switch on your mic or answer from the chat box.
Yes, you can switch on the mic also and answer. Okay, so here we want to point out that sometimes, parents' concerns may not align with the true problems that the child has. So height is at minus zero point 0.1 SD, which is obviously a very good height. The child is almost at the 50th centile. So why should they be bothered? And mid-parental height of 164 centimeter. If for boys you place 164 centimeters on the chart at 18 years, you will find that it is actually at the third centile. So child is actually tall for his parents. He's tall for his genetic potential. So what does that mean? When we see obesity, then being tall for your genetic potential is commonly seen in exogenous obesity. So children with obesity due to excessive energy intake, they are typically tall as compared to what is expected for that age and for their mid-parental height. And obviously the BMI here is at plus 1.5 SDS. And as we saw, this indicates that the child has obesity. So it is not overweight, he has obesity. And the concern is of short penile length. Again, the child is only 11 years, so he may not have entered puberty. It is okay to wait for the puberty to start, and many times penile length seems short. So we have to push back the pubic fat and actually measure the penile length properly and show to the parents also that the length is just appearing small because it is all buried. So that is how. So does he require thyroid function test? No, he does not require, because the height is normal. Child is growing normally. He has obesity, and typically you would order thyroid function test if the child is short as well as overweight or obese. And generally, the obesity is not much in hypothyroidism. Typically, obesity is mild. Would you like to do hormone profile? No, I don't think so, because the child has not even entered the age of puberty. Overnight dexamethasone suppression test is done when you're suspecting Cushing syndrome. So again, height of minus zero point 0.1 SD, which means normal height, which is tall for the mid-parental height, does not qualify the child to be screened for Cushing. Bone age, it's not going to serve any purpose. Fasting insulin, even this is not recommended. This is not recommended as a screening test for complications of obesity. So none of these tests are actually required. If you want to do some tests, these are some different tests which we'll come to later when we talk about screening for complications. So when we talk about etiology, almost 99% or even more are due to exogenous, which is more of calorie intake than expenditure. And of course, developmental origins also play a role here, that children who are born to mothers with gestational diabetes or obesity, or children who are born with IUGR but they have rapid catch-up growth, so they are more likely to develop obesity. But please remember that about 1% of cases may be having non-exogenous etiology, so we should be cognizant of that. So endocrine causes including hypothalamic, hypothyroidism, growth hormone deficiency, Cushing, genetic causes like syndromes like Prader-Willi syndrome, which is one of the relatively common causes of syndromic causes of obesity, then Bardet-Biedl syndrome, where the hallmark is polydactyly, which is a post-axial polydactyly, and generally the patients also have retinitis pigmentosa leading to vision loss, gradual vision loss. Then you have some monogenic causes like leptin receptor defect, MC4R mutation. Then there is Albright hereditary osteodystrophy, even Turner and Down syndrome. These patients are also more prone to obesity because they are short, and they are generally less active as compared to typical children. So obesity is common. Then medication, steroids, we all know. Then anti-epileptic drugs like valproate, and atypical antipsychotics like clozapine. So, what are the red flags that one should direct our attention to the possibility of an etiology other than exogenous? So, one is early onset severe obesity. So, very young child becoming more and more obese, very rapid weight gain, any dysmorphic feature. So, on the face we see, or as I said, polydactyly we see. Prader-Willi children typically have distinct faces. So those I will show some pictures. Short stature. So growth retardation. With obesity, typically exogenous, children grow tall. So being short is a concern. Developmental delay or intellectual impairment again indicates that it may be a syndromic etiology. Vision abnormalities, behavioral problems. and history of steroid intake or possibility of hypogonadism, which is again seen in several syndromes, including Prader-Willi syndrome, and unsatiable hyperphagia, like the child is just eating, eating, eating all the time. So again, we have to think of monogenic etiologies and Prader-Willi syndrome in this. So let's look at this child. Would anybody venture a guess? These are two different children. There's a girl child, and you can see the face, and again, the fat distribution seems to be more of central. The legs don't are not that affected. Here, what you can see is violaceous striae on the abdomen, stretch marks which are not white. White stretch marks are common. They are called striae albicans. They can be seen in any child with obesity, but these purplish striae are not that common. And here you can see the face of this child, and there is what mooning of faces, which we call, basically the cheeks are full. So what is this? Likely to be Cushing syndrome. Oh, sorry. So Cushing syndrome, typically they would have central obesity with short stature, round face, facial plethora, acne or hirsutism, hypertension. So measure BP, very importantly, please measure BP in all children with obesity. Mild hypertension, you can explain with exogenous obesity, but marked hypertension should be a risk marker. Striae, then features of catabolism, that is proximal muscle weakness, bone pain, backache. And if it is Cushing is because of an adrenal carcinoma, carcinoma means that it is a very rapid onset, then they have more features of excessive androgens. Even a young girl can have clytromegaly, and children often present like with precocious, peripheral precocious puberty like features. And sometimes height may not be that affected because it is a rapid onset kind of a illness. So etiology of Cushing, please remember, most important cause in children is exogenous intake. So always rule that out. The second is adrenal tumor or carcinoma, especially in younger children below 7. It is primarily adrenal origin, and older children above 7, pituitary microadenoma. So how do you diagnose? By doing various tests, including 24 hours urinary free cortisol, late night salivary or serum cortisol, overnight dexamethasone suppression test, and then of course to localize, you can do ultrasound of the abdomen and MRI. Okay, let's look at this child. So again, this child was mildly overweight. She was short for her mid-parental height and for her age, dull, sallow complexion, dry skin, truncal obesity, constipation. So this child had hypothyroidism. So sometimes children may not have very marked hypothyroid faces. Just dull looking child. Parents are saying that this child does not participate in sports. She just likes to sit. She's okay in studies because the scholastic performance is okay because they're not interested in studying or sorry, not distractible easily, not interested in playing. They're just happy to sit at one place and keep their book in front of them. So they're generally okay scholastically. And this is acquired hypothyroidism where you see mild periorbital puffiness, even the eyebrows are slightly sparse, and then all of these features. So hypothyroidism, acquired hypothyroidism, Hashimoto's being the commonest cause. Okay, this child, these two children, different children. This young child who was less than 1 year of age, and you can see marked obesity. And this is an older child, about 5-6 years of age when this picture was taken. And again, you can see marked obesity. Along with that, you can see there is genu varum in this child. And this child had very severe asthmatic episodes. So what are these? When it is very early onset and very marked obesity, then you have to suspect monogenic obesity. Okay. So monogenic means single gene mutation. And these mutations disrupt the satiety pathways in the hypothalamus and cause hyperphagia and severe obesity. And there are several genes which are known in our own sort of experience. Leptin receptor deficiency is one of the commonest in our North Indian population, and the second being MC4R. Okay. Then coming to Prader-Willi syndrome. So Prader-Willi syndrome, there are certain things like the faces is generally typical, almond-shaped eyes. I'm sorry, I have to use this thing to, but here possibly no, you can't see. Almond-shaped eyes, then narrow bifrontal diameter. No, narrow biparietal diameter. This the forehead seems to be narrow. Then you can see the tapering fingers, which are generally there. And what is the typical history? Prader-Willi syndrome children, they are born with low birth weight. In the first year of life, they generally have difficulty in feeding. So they may have failure to thrive, and they are floppy, hypotonia. Sometimes they come to light because they may consult a pediatrician or a pediatric neurologist because of floppiness, and or they may consult a doctor because the child is not feeding well. So this is the typical thing. And then the rapid weight gain typically begins after the first or second year of life. So in the first year, they generally have failure to thrive, low birth weight, failure to thrive, followed by onset of excessive eating and weight gain beyond the first or second year of life. Their IQ is typically between 60 to 70, and they have behavioral problems like stubbornness, or sometimes they pick their own skin and cause blood to ooze out. They're like, so much of skin picking behavior is there. Facial features, I told you. Then hypogonadism, that is the central hypogonadism is there. And diagnosis is typically established by methylation specific MLPA, MSMLPA. So Bardet-Biedl, again, developmental delay is there in these children. Retinitis pigmentosa, post-axial, it means this side. Post-axial is this side, not to the side of the thumb. Post-axial polydactyly is there, and kidney anomalies may also be there in some children, and onset of obesity is within the first year. Then AHO, Albright hereditary osteodystrophy. Here, this is the typical sign: knuckle, dimple knuckle. It is because your third or fourth metacarpal is typically short, typically the third metacarpal. So, and they may have pseudo hypoparathyroidism, that is low calcium, high phosphate, and high PTH. Or sometimes they may have pseudo hypoparathyroidism, means that they have the faces and the look of AHO, but their calcium, phosphate, and all are normal. So rounded faces is there, short stature, subcutaneous ossifications are sometimes present. So patient may tell you that there is a lump that they can feel, and when you feel it, it looks like a bony kind of a thing. It can present at any site of the body. And brachydactyly, as I already told you, in the X-ray also you can see both third and fourth metacarpal were short in this child as compared to the other two. Okay, let's come to another case. This is a 3-year-old child. This was the child when he came to us. He had rapid onset obesity, in which he gained 21 kilos over 9 months. So parents actually showed us this previous picture, which they had taken about 8-9 months back, and the child was absolutely normal looking child, and then he became grossly obese, and he had excessive snoring and breathlessness on walking. And he was investigated outside with an ultrasound, and it showed that he had a lipomatous ganglioneuroma in the right adrenal. And he was found to have severe obstructive sleep apnea. And when he came to us, he actually required ventilator support also for some time. So can anybody think what kind of obesity is this, where in a very short span of time, the child has gained so much weight? So initially, because of the adrenal mass, we thought, is it Cushing? But it was biopsy proven, like it was not an adrenocortical tumor, it was a ganglioneuroma. So this is a syndrome known as ROHAD. Okay, so So ROHAD, which is also known as ROHAD net, that is rapid onset hypothalamic obesity and autonomic dysfunction, and sometimes also associated with neuroectodermal tumor, like in this child, a neuroectodermal tumor. ROHAD net, it is a rare, potentially fatal condition, and it is characterized by dramatic weight gain, followed by involvement of the hypothalamic system. And sorry, just no. Yeah. So dramatic weight gain happens over a short span of time. And typically this happens in the first few years of life. So in this child, it happened at between 2 to 3 years. Sometimes we see it happening between 3 to 4 years. So, but generally early in life, in a short span of time. And then they have features of hypothalamic dysfunction, which includes obstructive sleep apnea, which also sometimes includes, they have either diabetes insipidus like picture, polyuria with hypernatremia, or they can have the opposite, that is adipsia leading to hyponatremia, or polydipsia but without polyuria leading to hyponatremia. So they can have disturbances of sodium, they can have disturbances of thirst mechanism and water intake, and they also have alveolar hypoventilation. And more than 50% are diagnosed with a neural crest tumor, majority within 2 years of onset of obesity. So we had last year, published this a case series of 5 cases that we had seen in our institute over the last 3 to 4 years. So you can read it to understand more about this condition. Then coming to prevention, I will not take too much time because I think we all know, but I'll try to spend a little more time on management after that. So prevention, of course, we all know that prevention is much better and easier also than cure, because once a child becomes obese, it becomes very difficult for the family to make the child lose weight. So there is definitely the pediatrician's role at the level of society through advocacy and awareness, and at the level of children and families in our care. Sorry. So this was the WHO Commission on Ending Childhood Obesity, also known as ECO, which was they published their guidelines in 2016, and they advised a 6-pronged approach. So healthy food, physical activity. They also included preconception and pregnancy care. Then in early childhood diet and activity, that is in the school, again, this is related to school, and then weight management. So this was their 6-pronged approach. So promote intake of healthy food. This is something which is very important. Of course, now there is a lot of stress on probably front of pack nutrition information, and we should all emphasize, sometimes parents think that this yogurt is healthy, or Glucon-D is healthy, or fruity is healthy because it is fruit drink. So we have to basically keep on educating parents who come to us that all sort of mislabeling or wrong marketing, all of these should be called out, because these are really causing a lot of harm to the patients, and especially when they give it to their child thinking that it is healthy. And again, in schools, there is a lot of role of schools to first include nutrition and health in their curriculum, maybe have food preparation classes, or improve the nutrition literacy of parents and children, physical education, food in canteens. So all of these should be taken care of. Then when we come to developmental origins, maternal obesity is now increasing. So this acts like the first hit. The fetus is already exposed to obesogenic maternal environment. And then if there is a second hit in the form of energy dense diet in infancy, childhood and all, then it can lead to obesity. So we should be cognizant of this. Then our own study, which we showed that SGA babies, when they had excessive weight gain in the first 6 months, then this weight was primarily constituted of fat. So we actually did their body composition, and these were the babies with and without catch-up growth, about 50 here and 54 here. So those with catch-up, this shows their overall weight, which was around 6 kg at 6 months in the without catch-up growth, and about 6.7 kilos in those with catch-up. So all the excess 700 grams was contributed by fat. So the catch-up is primarily fat. So that is also something that we need to be cognizant of. And life course perspective is there, that if you have a poor start to life, either in the form of GDM or obesity or IUGR, either of the extremes of weight, and then there is catch-up fat, sedentary lifestyle, and then ultimately you can develop all of these issues. Familial risk is also there. So it's not just that the mother is programming through her own weight, it is also the diet and lifestyle choices. So I think prevention is, I think we all know, I will not spend much time here. We can go straight away to management. So in which we have screening and then stepwise management. So complications of obesity are manifold, right? I think all of the systems can be involved, right? From pseudotumor cerebri in the neurological to psychological issues, sleep apnea, we've already talked about, steatohepatitis and gallstones, then musculoskeletal conditions, endocrine, we're all familiar with, type 2 diabetes, PCOD, hypogonadism, and cardiovascular. So this is again from our own data, which we had published in 2018, where we had looked at children who were, the mean age was 11.9 years, BMI Z-score was plus 2.3, mean BMI Z-score. And here, if we look at the complications, various complications, elevated ALT was seen in almost 78%, and HOMA-IR more than 2.5, which indicates insulin resistance, was the second commonest thing, seen in 65%, and then rest of the others. So we know that all of these complications are there. So there are guidelines for screening. So for pre-diabetes as well as diabetes, you have to start screening all children above 10 years who have overweight or obesity. And we know how to diagnose. Dyslipidemia should be done at first visit. You don't have to wait for 10 years of age for dyslipidemia. You have to screen even younger children. Please remember that in dyslipidemia, sometimes it can be a familial hypercholesterolemia. So therefore, the guidelines are there that you have to do it at the first visit at whatever age you see the child. And then every 2 years, ideally, you should screen for it. Hypertension, above 3 years, you start screening at every visit. And the hypertension guidelines are there where we follow this. Elevated BP is between 90th to 95th centile. And in children above 13 years, anything above 129 and anything above 80, even including 80 diastolic is considered as elevated BP. And then you have stage 1 and stage 2 hypertension, which we all know. And then a NAFLD, which is now known as MASLD. So again, you look at ALT and AST levels, and then ultrasonography or fibroscan can be done. Others, based on the history, we should screen for sleep apnea, PCOD, psychological and musculoskeletal conditions. So management is multi-pronged, but I think I want to emphasize on family's involvement. So if the parents themselves are watching TV or watching content on OTT or whatever all the time, and then they ask their child to keep the phone down and go out and play, that's not going to happen. So parents have to basically be the role models themselves. So whole family has to be targeted for behavioral change. And you have to set incremental goals and incentivize the child. How do you incentivize? With praise and with rewards. So this has to be done. So if we actually, when we write on the card, when we see an obese child, we just should not write, okay, try to lose weight. You have to give some idea how much weight loss you're aiming at. So for 6 to 11-year-old children, if the child is in overweight range, you tell them to maintain weight. They should not gain weight in the next 6 months or so, and they should come back to you with the same weight. And ideally, they should maintain weight till the BMI falls below the overweight centile. If the child is between 6 to 11 years but already has obesity, then you recommend slow weight loss of 0.5 to 2 kg per month, depending on the severity of obesity, and targeting ultimately a 10% weight reduction. So this is very easy, which is something which we always follow, that if the child is 60 kilos, we tell them you have to lose 6 kilos. And how do you lose them? You can lose up to 2 kg per month. So 6 kgs you can actually lose in 3 months. So this is the target that we give them, that you have to measure your weight, and it should not be just ki thoda weight lose karna hai. Kitna karna hai, wo batana hai. Similarly, for older children, we can be even more aggressive. Weight loss of 1 kg per week can be done. So if you're seeing an adolescent who weighs 100 kilos, the target weight loss is 10 kilos and they can achieve it over 10 weeks. So this is sort of the active phase where you tell them that, okay, over 10 weeks, you need to lose 10 kgs. And then in this period, then they should be actually following your advice very, very carefully. That is important. Okay, so sometimes when you give a lot of advice, this you have to eat, this you don't have to eat, the children just become rebellious. Why should I change my diet so much? If you give them a timeline, okay, this is only for the next 3 months. Please do it for the next 3 months. Say no to sweets, eat healthy, eat salads with each meal. Try not to have any colas, try not to have any ice creams in this summer. Let's see how you fare, and then you will feel very happy about it. So you give them just, okay, for 3 months you have to do it. In children, this giving a timeline is very important. And then once they lose, that itself becomes an incentive. When they see that the weight is falling on the weighing machine, then they themselves become motivated to lose further. So dietary management, as I emphasized, there can be green, yellow, red. I think Sheryl will take it further, so I'll leave it. And only thing is just tell them what to eat and not just what not to eat. This is important because many times parents say, "Kuch bhi nahi khata." My child does not eat much. He hardly eats anything. But then whatever less he is eating or she is eating may not be healthy. So you have to tell them you have to eat. Don't skip any meals. Take more salads with each meal. Eat healthy. plain packaging. Of course, I don't think we can ever reach here where we actually show these pictures on the card, on the boxes, then nobody would like to eat these things. Physical activity, the recommendation is 60 minutes of moderate to vigorous activity at least 5 days per week. Moderate means activity in which the child can talk but not sing. Vigorous means when the child finds it difficult to talk. So you have to explain it to them. That brisk walking does not mean कि आप आराम से चल रहे हैं and you're singing along with that. No, you would find yourself a little breathless, and always tell them to be gradual about it, so that sudden activity may cause some problems. Muscle strengthening activity also should be done. Sleep recommendation is 8 to 11 hours a day, screen time less than 2 hours per day. So there are levels of intervention. I will not go into the details, but at each level, basically, the intervention can become more structured. Yoga is also a good way to lose weight, and we had shown that yoga in conjunction with diet and activity can actually improve the weight loss. Pharmacotherapy, there are limited options, and the drugs don't have great efficacy, and they would have side effects also. So we need to be careful about that. So one drug which is approved is Orlistat. Orlistat, as we know, is a pancreatic lipase inhibitor. It is approved for children above 12 years, but it causes oily stools, vitamin deficiencies, and only 10% of those who are prescribed it continue it because of the adverse effects. Then the other drug is metformin. Metformin is actually not approved for obesity. It is approved for treatment of type 2 diabetes, and it is found to be useful in insulin-resistant states such as PCOD. Not really approved as a treatment of obesity, but it does lead to some modest weight loss when it is used in conjunction with diet. Then what is now coming up in a big way is GLP-1 analogs. And various studies have shown that GLP-1 analogs like liraglutide, semaglutide, they can cause approx 5 to 16% BMI reduction over 1 year. Then one more drug which is approved but it is not available in India is the combination of fentanyl and topiramate, which causes again a BMI reduction of 8 to 10% over 1 year. But if you see our own obesity, like the yoga study and all, we were able to achieve a 10% weight loss even with yoga and diet. So it's not that these drugs are causing a miraculous kind of a weight loss. It is actually easily achievable if the child and the family put their mind to it and they are guided nicely by the team. So GLP-1 analogs, just a little bit about it, that they basically act in various ways, lot of different ways. Directly at the hypothalamic level, they cause increased satiety, decreased appetite. From the pancreas, they increase insulin secretion, and insulin, we know, ultimately leads to increase in satiety. So they reduce insulin resistance. Gastric emptying is delayed, so the patient feels full after eating. And hepatic steatosis is also reduced. So these two are approved. Liraglutide was approved in 2020. It is a daily injection, and semaglutide was approved in 2022 for children above 12 years, and it is a weekly injection. Contraindications, please remember, anybody with a history, either personal or family, of MEN2, that is multiple endocrine neoplasia type 2, or medullary carcinoma of thyroid, they should not be given. So please take this history before you prescribe, and history of pancreatitis. These are contraindications. Also, as we know, there are now several reports that it may be associated with suicidal ideation, depression, or some ocular abnormalities. So one has to be careful that these should be given after a good trial of diet and lifestyle management. Only when you find that there are, these are not helping, the child has very marked obesity, the family is committed to using these drugs, then we can try. So management of complications, I think we can leave this in the interest of time. Then surgical management, again, what is the recommendation? How do the surgical management techniques help? One is, of course, the anatomical reduction. The space available for food to get into the stomach, that is reduced, but also decreased ghrelin, because we know that ghrelin is secreted. Ghrelin is the hunger hormone, and increased GLP-1. So these hormonal things also lead to improvement in satiety. So many times it is seen that those with complications, they are also reversed after bariatric surgery. There are various ways that you can do it: adjustable gastric band, Roux-en-Y gastric bypass, or a vertical sleeve gastrectomy. Anything can be done. Recommendation is for adolescents more than 13 years of age with extreme obesity and persistent comorbidities, despite following a rigorous diet and lifestyle modification, generally advised only beyond Tanner stage 4 or 5, not in growing children who are in early puberty. and either in class 3 obesity or class 2 with significant comorbidities and without any psychiatric issues. They can have malabsorptions later, and therefore these should be taken care of. So I think I'll start with the key messages that obesity and its metabolic complications, they are silent epidemics in children, compromising their physical, emotional, and social well-being and reducing the life expectancy. So for prevention of obesity, there should be clear and persistent health messages from all of us as pediatricians. That is, monitor the BMI, be wary of upward centile crossing, keep waist circumference less than half of the height, say no to packaged, high fat, sugar, and salt foods, and say yes to 60 minutes of activity a day. Early onset, insatiable hunger, short stature, stage 2 hypertension, dysmorphism, they're all red flags to possible non exogenous etiology. So don't miss those etiologies, but don't over suspect also. Don't do unnecessary investigations. Screen for and manage the complications, and integrated lifestyle approaches with focus on mindfulness and a strong component of motivation and support are useful for weight loss, and parents' actions speak louder than words. Thank you. And this is a book on for MD residents on pediatric endocrinology, a case-based kind of a book. Like I had also shown 2 cases here, so those who are interested can read it. This edition came out in 2024. Thank you very much.
Thank you, ma'am, for wonderful insight of all aspect of obesity in the pediatric population. Now I will request our guest of honor, Dr. V. Bansal, sir, for his comments. Ravi, sir. Sir, sir, you're muted.
Yeah, it's a very nice presentation, very detailed overview of obesity. Whatever we know about the obesity is the parents are already over-informed about it. But whenever we guide them about the lifestyle, whatever you give instructions to the schools, all the CBSE schools have canteens full of junk food. In spite of repeated reminders to them, in spite of repeated reminders to the parents. In fact, what I have experienced, I am a main taken charge of this Ayushman school health program also in Punjab. But what we have seen, the parents are the most culprit now. They are screen addicted, junk food addicted, and it's very difficult to control all these issues. This is one comment. And another is any medications which you feel which can be helpful in obesity, if you can guide us a little more practical way.
Yes, sir. So I completely agree that obesity is more of a social problem, and the obesogenic environment, children actually are unfortunately sort of victims of it, because whatever they like, whatever is available in the fridge, whatever good things the parents say, okay, this is something good that we have brought for you, it is all unhealthy, unfortunately. So, and healthy is considered as equivalent to being less tasty and useless kind of stuff. So that mindset has to change, and parents have to play the major role. For medications, as I showed, that actually the 2 medications that we can currently talk of, one is Orlistat, which is a pancreatic lipase inhibitors. It affects the absorption of oil or fat from the intestine, but then that fat is lost in the stool, and there is also some incontinence issue, bloating issue. So Orlistat is an oral drug which has actually never really taken up because of the side effects. So people don't like to take it. The other is, of course, now everywhere GLP-1 analogs, the liraglutide, semaglutide, Wegovy. Wegovy is now advertising like anything. They are, sort of just advertising in lay press. They have taken up.
What is the cost of these injections, which is weekly?
Sir, semaglutide is once a week injection. I think they give some sort of discount also, but I think still the monthly cost for like 4 injections will come to somewhere around 15 to 16,000, I guess.
Okay.
Be something like that. And then it has the adverse effects which we should be aware of. And the BMI reduction that they can get with this ultimately is to the tune of around, at the most, in few patients they have shown up to 16%, but that would be rare. In the majority, it will be to 10%, and it has to be continued. Whenever you stop it, even after you stop it, after reaching a normal weight, the minute you stop it, you will start regaining. So there is no point, there is no exit. You have to just enter and then continue taking. So, and there are adverse effects. So better is to actually try to prevent, but what can we do? Sometimes we have to take, resort to these things.
But I think we should start from home. Whenever you go to the IAP meetings at district level, at state level, national level, a lot of junk food, and all doctors are going.
But
Not
doctors eat occasionally, that is why I said occasional treat everybody likes. I mean, residents like to go to meetings only because of the good food. If they get boring food over there, they won't go. So,
Mhm.
but sometimes people make it a daily habit. That becomes a major issue.
Yeah, very right.
Thank you, ma'am, for clarifying. I think Ozempic that market is blown away. That same is semaglutide and uh, not much trials, I think, in pediatric. I can see full CMC team is sitting. So Dr. Monica Sharma, ma'am, any comments from you? Actually, they are projecting in that seminar room. Full class is there. So
Yeah,
any question, query?
we generally do that. We do it in the classroom so that whoever is free can attend. Firstly, I just want to thank Dr. Vanna for a very enlightening talk. Obesity is a epidemic, and exogenous obesity is rising. I feel personally that the changing diet pattern from the Indian cultural diet to the Western diet is one of the primary causes. And I don't know, have we reached a point of no return? Are we ever going to go back to our cultural foods? I do see a little bit of turning around because I see new parents coming and talking about not going for food fads and trying to give homemade food, which is a good thing. It's a positive sign. I just hope it carries on and we can get over this epidemic.
Yes, ma'am, you're very right. And it is very heartening to know that some young mothers, they are very aware that below 2 years, we should not be giving too much
Yes.
of meat or extra added salt or these things. They're very, and then some people are going back to millets. So some signs are there, but yes, just, yeah, probably too little. But maybe, PM is also making these, repeatedly he's calling for, less oil and more walk and Kelo India and all those things. So I hope that there is some change.
Yes. Yes. Thank you so much. It was a wonderful talk.
Thank you.
Thank you. Now we'll thank you for expert talk and all the queries and question discussion. Now we'll move on to our next speaker of the day, Cheryl ma'am, who is renowned dietetics and lead educator in type 1 diabetic education. Over to you, ma'am.
Thank you so much, Dr. Seema. Am I audible? And
Yes, ma'am.
right?
Audible and visible.
Yeah, I think we had a fantastic session by Dr. Vandana, and I could relate completely to her when she was talking about the diet because typically, when it comes to children, it's very difficult because, they are exposed to their peers, their friends, and of course, childhood obesity is on the rise. And then parents often find it very challenging to get them. One is to eat right, and secondly, I think with the kind of pressure, especially come eighth, ninth standard, it's very very difficult to find time to even do any kind of focused exercise, and they're only running from one class to another and preparing for competitive exams. So it's always a challenge, and I'm going to just share with you. One is definitely what sorry, can you see my
Slides are not visible.
yeah, I'm showing them now. Can you see them now? One second.
Yes, ma'am.
Yeah.
It's there. Yeah. Thank you.
Okay.
Just minimize this icon. Yeah.
How do I do that?
Just cross it.
Because I'm not very well versed with. Okay, now you can see because then
Yeah,
I
yeah.
can't see all.
This is good, ma'am.
This is good, right? But I can't see all, so that's okay. So I'm going to be speaking about dietary habits for prevention of childhood obesity. And at the outset, I'd like to thank you, Dr. Seema, and the entire team for inviting me to speak on this topic. And this is definitely a very burning issue that we are facing at this moment. Sorry, my thing is gone. Just give me a second. I'm having a little bit of an issue. And again, I'm going to discuss one of our cases where, I mean, we have, honestly, in our clinic now, we're seeing a rising number of children, adolescents, and young adults with obesity, type 2 diabetes, and, MASLD, PCOS, and precocious puberty. And, this is a 13-year-old male child. If you see height, weight, BMI, waist circumference, so basically obesity and central obesity, acanthasis nigricans, pre-diabetes, HbA1c is 5.7, elevated lipid levels, triglycerides are 173, total cholesterol 216, elevated AST and ALT. When we took the history in terms of, what is the screen time, we realized he's doing around 4 to 5 hours of screen time per day because the mother is working, there's nobody monitoring at home, and there's a lot of online gaming that happens after school. Physical activity is nil, and father's working abroad, lives with working mother and aunt. And childhood obesity with insulin resistance, dyslipidemia, pre-diabetes, and MASLD. And the child was referred to us for management of obesity, and of course all the metabolic health issues that he had. When we took the recall, we saw that he was having milk with half glass of milk with sugar and cereal in the morning. 11 o'clock was a mayo sandwich or salami chicken sandwich. This child was a non-vegetarian. He was a Catholic boy. And because the mother did not have too much time, was looking at ways on, with her work, trying to, even prepare his meals. Lunch was white rice with dal, vegetable. And if he did not like the food, he would order in. Evening was typically 5 to 6 rusk. I think a lot of children and adults even like toast, what they call it as rusk or toast. Khadi biscuits, 1 packet of biscuits, namkeen chips with one glass of packet juice. 7:30, if hungry, then there was a snack again because the food was not ready. Mother would come from work only at around 7 and then start cooking. And then 9:30 would be dinner, which was typically either chapati, vegetable with fried cutlets, fish fry. And again, if not, then ordering food. Very fond of burgers and pizza, and ordering in was at least twice a week. So not surprising that we see these reports and the weight. And this is extremely concerning that, fatty liver is India's new silent epidemic. And this is from the newspaper cutouts. Why every 1 in 3 children have it. And this is so true. Now we don't call it, fatty liver, we call it MASLD. But yes, this is a rising concern in our children today. This is from our own study. So we did a study where we screened around 1,313 adolescents and the young adults in the age group of 16 to 25. And here we basically looked at data of 16 to 19 years. And we saw that the prevalence of overweight and obesity was 15 and 20.5% respectively. And if you look at, the children with family history of diabetes also was pretty high. The waist to height ratio was 15.6%, which is more than 0.5%. So 112, which is 8.7%, had elevated fasting insulin levels, and 31% had higher than normal 2-hour stimulated insulin levels. And like Dr. Vandana said, I think this is something that our children are constantly exposed to, and even all of us, it's an obesogenic environment. Today, we really don't go out to the parks or, to see around. We actually go to the malls, and again, it ends up with eating the HFSS foods, which is high fat, sugar, and foods. Our exposure to TV screens has become very high. In fact, a lot of parents, right from childhood, make habits for their children to watch their phones when they're eating, because that's the only way to get the child to eat more. And that is where the trouble actually begins. So there's a lot of exposure to screen right from, through the day, and especially when eating. Advertisements, again, lure a lot of children to eat unhealthy food. Again, like Dr. Vandana said, portion size is something that we need to look at, because parents say that the children really don't eat too much. But if you look at the quantity of calories is very high, the quality of calories is very low. So it's nutrient poor, energy density food that our children are consuming. And this is again from a survey by CSE in 2019, which was done in 13,200 children in the age group of 9 to 14 years. It documented that 93% of children eat packaged foods, 68% consume packaged sugar-sweetened beverages more than once a week. And this is very common today, because you do have all the sugar-sweetened beverages, the milks as well, the flavored yogurts, the juices, and all of that is consumed very commonly in our children and, adolescent age group. 53% consume packaged foods or beverages once a day. And almost one-fourth of these school children consume ultra-processed foods, which is burgers, pizzas, from fast food outlets more than once a week, also because of birthday parties. I think in a week, at least the child would have one or two birthday parties, and therefore, again, consumption of HFSS foods become very high. Now, this results in high energy diets, eating fewer fruits and vegetables. So, again, even if you look at the Eat Lancet report, it very clearly states that we Indians eat fewer of our protective foods, especially fruits, vegetables, as well as dairy. And there's excess consumption, of course, of carbs coming from cereals, but also there's frequent dining out, eating fast foods and ultra processed foods. And therefore, we are having something that we call as hidden hunger. That's micronutrient poor, low in fiber, but very high on energy density, high on fat, especially saturated fat, trans fats, sugar, and salt. And this is what is actually resulting in, obesity, as well as, more importantly, adiposity, and all the metabolic parameters are getting deranged because of this. Now, the management of obesity, we have dietary and lifestyle modifications, which of course are the first line of treatment, like Dr. Vandana stated, and then there is pharmacotherapy if this does not work. But again, diet and lifestyle modifications go throughout, So we start with it, but even with pharmacotherapy, especially even if the child is on a GLP-1 therapy, diet and lifestyle becomes very, very important. Now, this is from the Indian Academy of Pediatrics revised guidelines, which was published in the year 2023. Again, gradual weight loss. Again, we are looking at adjusting the weight in the height. The focus is on healthy eating, on optimal growth and development, and therefore we do not really recommend very low calorie diets or very nutrient depleted diets, because of course the focus is on growth and development and adjusting the weight in the height. So for the management of children with severe obesity and or those with comorbidities or complications, a gradual weight loss is recommended. Dr. Vandana has already spoken about this. It's 0.5 kg per month for 2 to 5 years and 1 kg per week for older children and adolescents. Again, no calorie restriction before 6 years. The focus must be on healthy eating, activity, and weight maintenance. I'll just give you an example. We see a lot of children diagnosed with type 1 diabetes, and then the parents come back to us and say, whenever we recommend curd or yogurt, they say, the child is refusing to have the curd or yogurt or even milk without sugar. But who has actually made that a habit? The child did not know that they have to have the milk or the yogurt and curd with sugar. So therefore, we always emphasize that, healthy eating should start right from the beginning, because otherwise it becomes very difficult to change habits that are one formed. Encourage healthy eating. Again, very important is the family. It is not only the child, it is everybody in the family. We often find it very challenging where the child is really motivated to do it, but does not get that kind of support from the family. Either they're staying in large joint families where the other children are eating a lot of unhealthy food. Sometimes even parents, I always tell the parents, your children will follow your footsteps and not your advice. You cannot be sitting on the couch and watching television endlessly and then expect your child to go down and play, or you eating unhealthy food and expect your child to eat healthy. So it has to be something that the family needs to do together to be able to, create an environment which is conducive for healthy eating, and of course then, achieving all the goals that is set for this individual or for the entire family. Therefore, it is recommended that 80% of effort for obesity prevention should focus on improving the diet and 20% on increasing physical activity. Again, another thing that we'd say, like Dr. Vandana said, that it becomes very difficult when you're constantly telling them to go on a diet. The children really cannot do it. Anything which is extreme is not going to be sustainable. And therefore, we follow the 80-20 principle, where 80% of the time we tell them to eat home-cooked meals, and 20% of the time, if they do want to indulge in outside food, they can. But it could be a better thing to have it in the afternoon. Say, the family is used to going for lunch every Saturday or Sunday, or for a meal outside on a Saturday or Sunday. We usually tell them that try and keep it to Saturday or Sunday afternoon, so that one is that, they can be more active at the remaining time of the day. And also because they've indulged in a slightly higher amount of food for lunch, they would typically end up eating lesser at dinner, and therefore they could actually balance out the calorie consumption. Now, prevention of childhood obesity starts right from the beginning, and therefore today we are focusing on the 1,000 days of life, and nutrition becomes a very, very important component right from womb to tomb. And therefore, today we also focus on healthy eating in women even before they plan to conceive. So, promoting healthy maternal weight in the prenatal period, smoking cessation before pregnancy, appropriate gestational weight gain and diet. And today we are very happy to see a lot of women who consult us while they are expecting or even before they get pregnant for healthy, eating and healthy pregnancy. Again, exclusive breastfeeding in the first 6 months, ensuring appropriate weight gain in infancy, and transition to balanced homemade complementary foods, avoiding salt and extra sugar, avoiding packaged foods and forced feeding. And again, another important thing that we need to look at is early adiposity rebound, because there's a higher risk of obesity and metabolic disease later in life because of early adiposity rebound. Dr. Seema, you can hear me? Am I audible? I'm
Yes,
sorry,
ma'am, you're absolutely audible.
Yes,
Dr.
audible.
I can't see all that, so I'm just asking.
Okay, okay.
Okay.
So
Now, again,
someone raised hand, Dr. Kochirami Abram. I would request him, please type your question or comment in the chat box.
yeah. Again, we have, the AAP clinical decision support, which recommends mnemonic 5210 rule for prevention of obesity among children, which is consumption of at least 5 serving of fruits and vegetables per day. And this is always a challenge. We often hear mothers say that children just don't eat vegetables. Some children we know that who eat lady's finger or okra 365 days a year for lunch and dinner. There's no other vegetable they eat. So this is always a challenge. And of course, we have to find ways on how we can get vegetables into their diet. Fruits is also seldom consumed, and there is no focus on these two, food groups which you need to incorporate in the diet. Limit screen time to less than 2 hours per day. Participation in 1 hour of physical activity every day, and zero intake of sugar sweetened beverages. So this is the 5210 mnemonic, which is recommended by the AAP. Again, when we are looking at, we take a detailed history. So honestly, in our clinic, we spend around 1 to 1.5 hours with each family that comes to us, because we are trying to enforce a change in the entire family environment when it comes to eating, lifestyle, sleep, etc. So we take a detailed dietary recall, we plot the growth charts, we understand the breastfeeding history, we do the body composition. We also look at all the investigations and the doctor notes all the clinical examinations that could be done to rule out any other causes of obesity, like Dr. Vandana mentioned. Consumption of junks, which is junk foods, ultra processed foods, nutritionally inappropriate foods, carbonated, colored, caffeinated foods, beverages, and sugar sweetened beverages. We look at portion size. So we also have sizes of chapatis in our clinic. We have cups and spoons to understand what is the portion that the person is consuming. So when it comes to rice, whether is it 1 cup rice, and the cup measures could be very different in different households, and therefore we have standard measuring cups and spoons. We understand the snacking pattern, who's cooking food at home, what does the child eat, especially when the child is bored or when the child is upset. So what are the emotional triggers that trigger the child to eat? We also understand about school, what is available in the school canteen, because today, I agree that we have very, very plush schools. We have IB schools and we have different kinds of schools, but the kind of food that is actually there in the cafeterias are atherogenic and obesogenic. Most of the schools offer very high HFSS foods. Most often, we also see desserts in their lunch menu, which is there every day. And that itself is actually triggering obesity in our children. And therefore, it's very, very important that we work closely. I think this has to be a government mandate to definitely make schools serve healthier foods, more closer to home cooked meals, and definitely not something which is going to cause more obesity in the future. And screen time and sleep duration. Again, physical activity is a challenge. Like I was mentioning, we do see children, especially after grade 8, when they go into grade 9 to 12, And in that 3 years, sometimes they've gained already 20 to 30 kilos because they've had no time for physical activity because of increased pressure of studies. And that also impacts their sleep. And also sleep is impacted because they're watching TV late, or they are playing games or binging on Netflix. Now, goals of meal planning, it has to be well balanced meals, keeping cultural preferences in mind. And this becomes very, very important because we as a nation, we are so diverse. North eats very differently to South, South eats very differently to East and West. And there are some who love eating rice, whereas you have the North who love their chapatis and parathas, and therefore that has to be kept in mind. We have to look at what is the total calorie consumption, and therefore lower the calories, but very importantly is moderate the carbs, low in fat, low in sugar, and no diets which eliminate food groups, because these are extreme diets and they are not sustainable. They could also have long-term harmful effects, especially your ketogenic diets, etc. It has to be the right quantity and quality, and therefore portion control is something that we need to emphasize on, and growth and development has to be monitored and tracked. These are the recommendations by the NIN. Some of it could be too much, and therefore we have to look at what is the current consumption of the child and then modify it accordingly. Also, the RD for nutrients is given. Again, we're seeing that children with obesity are more prone to develop iron deficiency with or without anemia. Therefore, active screening and treatment of anemia is recommended. Many children are likely to have other deficiencies like vitamin B12, zinc, vitamin D, etc., which needs to be addressed. Now, when we look at the carbohydrate recommendations, we clearly see that Indians consume a lot of carbs. And we have the recent ICMR India 23 paper, which has clearly stated that we Indians consume around 62 to 63% of our calories coming from carbs. The quality of carbs is also deteriorated over the years, and therefore there's a lot of consumption of refined and simple sugars. So if we can bring down the carbohydrate from, say, 62 gradually to around, say, 50%, and if possible, say 45%. This is from the SPAT guidelines when they're stating 40%, but their population is very different. So we can at least try and bring it down to, say, 45 to 55%, whatever is achievable and sustainable. The focus must be on high quality carbohydrate to minimize glycemic excursions and improve dietary quality. Moderate the amount of sugar intake, because there's a lot of consumption of desserts and sweets and sugar sweetened beverages. Carbohydrates should not be excessively restricted in children and adolescents, as that can be nutritionally inadequate and result in growth failure. And therefore, we have to look at the total carbohydrate consumption, also look at improving the glycemic, the load. So basically lowering the glycemic load and the glycemic index. Typically, we see that children will have, these cereals because they're widely promoted by advertisements and social media platforms. But these cereals are very high in terms of their glycemic index, especially your cornflakes, your all bran flakes, chocos. You have so many of all these cereals which are very high on glycemic index, and therefore that itself can actually result in insulin resistance and MASLD. And therefore our traditional Indian breakfast would be the right thing to consume. And again, whether it's any part of the country, north, south, east, west, these traditional meals can be tweaked to make it more healthier and moderate in carbohydrate and higher in protein intake. Again, emphasis should be on fiber. For example, if somebody in South is having, say, puttu with kadla, you can reduce the amount of puttu, increase the amount of kadla, so there's more amount of protein, lente carbohydrate, and fiber. Same thing for a person in North, if they're having parathas, instead of aloo paratha, you can make it like a paneer paratha or a sattu paratha and add some vegetables and have it with a cup of yogurt. Automatically, the carbohydrate content will be lower, the protein content will be higher, because they're complementing two food groups such as cereal and pulse. The protein quality is also improved, and therefore satiety is achieved much faster. Include vegetables raw, cooked in meals 2 to 3 times a day. Now, the most important thing is fructose. And today we know that fructose is more adipogenic and lipogenic than glucose. And fructose from fruits and vegetables is fine. Of course, we need to moderate the amount because we have a population which is very, very high in their food consumption. So we have to tell them how much to consume, because we do see its impact on triglycerides, high uric acid levels, etc. However, the fructose coming from our packaged foods in the form of high fructose corn syrup is the real culprit. And that is something that we need to avoid consumption of. And this is something that we need to educate our families on, that, what are the foods which actually will have the high fructose corn syrup. So naturally occurring fructose sources like fruits and vegetables, because of their high fiber intake, and I'm going to talk about fruits versus fruit juices, but HFCS, which is coming from all your packaged foods, needs to be avoided. And again, all the hidden forms of sugar. Sometimes you have a product which is labeled as sugar-free, but when you actually look in, there could be either maple syrup or jaggery, or there could be something else. Today, FSSAI has made their norms very, very strict, where they are mentioning that, or they have mentioned in their guidelines that, these industries should actually call out all the sugar that is there in their products. So it has to be labeled and it has to be mentioned separately on the food label. Then we come to fat recommendations. So why they are moderating the amount of carbohydrate, again, to meet calories, we are looking at least 15 to 20 grams of visible fat. And again, the fat recommendations would differ with age, but definitely we need to restrict the amount of saturated fat, because most of your packaged foods would have palm oil, whether it's your biscuits, whether it's your namkeens, because it's more economical, but that is a form of saturated fat. Down south, you will have coconut oil. So in moderation within the recommended amount, saturated fat is okay, but anything in excess is not going to be good. The focus needs to be on more monounsaturated fat and omega-3 fats. But we all need to understand that fat is a dense source of calories, and therefore, when we are restricting calories, we will also have to restrict the amount of fat coming from your visible fat. Because sometimes when you have a cook cooking at home, they want to go from one house to the other in less than 1 hour. And therefore, to cook the food fast, they end up actually using more oil. And then we're eating a lot of packaged foods, and then we're ordering it and eating out. The fat consumption goes very, very high. In fact, again, the ICMR India study clearly has shown that we Indians consume a lot of fat coming from saturated fat, and more than 27% of calories coming from fat actually predisposes us to all the metabolic conditions. So this is the healthy food plate. Again, what we prescribe has to be sustainable. It has to be something which is easy to follow. It should not require the mother or the cook to be in the kitchen all day. So it's a simple home cooked meals which has to be balanced well. Because typically, if you see, sometimes they're not able to get that balance. We're either eating only roti and sabzi, or we're eating only dal and rice. We're not really focusing on including all the food groups, therefore making it a nutrient poor diet, or that is where hidden hunger arises. And again, this plate, which is from the RSSDI 2025 guidelines, we emphasize that 1/4 of your plate should be starch, cereals, and millets. And it's important to note that even potatoes or root vegetables come in this category. A lot of people will call, potato or any root vegetable as a vegetable, but it features in your cereal section of the plate. So that's 1/4 of your plate. 1/4 of your plate should be protein, and this is something which is missing in our Indian diet. So when we actually follow the plate method, one is we can actually moderate the amount of carbs, improve the amount of fiber in the diet, as well as improve the amount of protein, and therefore achieve a well balanced, nutritious plate. Again, more color on the plate, because one is it's visually more appealing. Secondly, is more color means more antioxidants. Follow the food order. So start the meal with a salad or with vegetable, or maybe a bowl of a soup which is not having cornstarch, etc. So a vegetable soup or a chicken vegetable soup is good, or an egg vegetable soup is good. And then have the protein, and then follow it up with the remaining of the meal. Because by doing this, we can blunt the post-meal glycemic spikes and also suppress the ghrelin levels, which induce hunger. Now, these are the child one guidelines, for people with dyslipidemia. So total fat, 25 to 30% of daily calories, saturated fat, 8 to 10% of daily calories, MUFA plus PUFA up to 20% of daily calories, and cholesterol less than 300 milligram per day. So while we are at this, a lot of times, even I am guilty of the fact that in the past, we used to tell people to discard the egg yolk. But today we say you can consume the egg yolk, even if you look at one egg yolk, it has around 2.2 grams of of saturated fat and 183 milligrams of cholesterol. So it is well within the limits. And if they want to have more, maybe it can tell them to have one whole egg with 2 egg whites. It'll give them around 12 grams of protein. But most importantly, it actually gives better satiety, and therefore the chance of craving or binging in between two meals will be lesser. The child 2 guidelines limit total saturated fat to less than 20 to 25 to 30%, saturated fat to less than 7%, and cholesterol to less than 200 milligrams per day. Focus on reducing simple carbohydrates, because if a child has got elevated triglycerides, high uric acid levels, this is mostly from your refined sugars and also just being overweight. And increase the amount of complex carbohydrate, especially fiber containing foods, high lentil carbohydrates such as your pulses, barley, legumes, etc., and also high resistance starch foods. Now, in South, we have people consuming raw jackfruit flour. You have your raw bananas. These are all high in your resistance starch, and of course your legumes, etc. Now, dietary modifications, again, it has to be very, very simple, something which the entire family can follow, nothing very exotic, because we have to even look at affordability. So it is not necessary to include quinoa and, chia seeds and broccoli and bell peppers, because this becomes extremely expensive. Also, somebody is not used to having this on a regular basis. Somebody would have never tasted quinoa and now does not have the palate for it. And therefore, whatever they've been traditionally consuming, also go back. We have written a beautiful paper which is reinforcing traditional Indian foods. When I tell people in east of India to have pakada or panta bhat, they remember their childhood. When we tell certain people in Bihar to have sattu, and they say, oh, we've always been consuming sattu. So, taking them back to what they've been eating from their childhood. Actually, one is they relate to it, and also talking about portions, because I know a lot of dietitians, so-called celebrity dietitians, who say that eat like what your grandmothers ate. But remember, our grandmothers did a lot of physical activity. I have memories. I'm from south of India, and I have memories of my grandmother waking up every single morning and grinding atta on the grinding stone. They didn't need to go to a gym, and then they were on the field. So there was a lot of calorie expenditure. So they needed to eat that much. We really do not expend that kind of calories. And therefore, portion control needs to be kept in mind, even if it is healthy. So fresh home cooked meals over packaged foods. We always tell our children that, eat food which is grown on plants and not which is manufactured in plants. Prefer fruits over fruit juice, because to make a fruit juice, you will actually, use at least 5 to 6 fruits, juice it, the fiber is gone, and you really don't achieve satiety. Emphasize fiber-rich whole grains, legumes, fruits, and vegetables. Reduce the consumption of refined carbs, ultra-processed food. So again, lesser amount of packaged food. The 80-20 principle works really well, and follow healthy cooking methods. We always encourage our parents. Today, I think in the time of, Instamart and Blinkit and Zepto, we hardly go into the market. We're all ordering food on the apps. So we always encourage our families, to go back to their childhood days and go to the market and shop. Again, eat seasonal local fruits and vegetables. We tell them to take the children along with them, take a basket with them, fill the basket with 5 or 6 different kinds of fruits and vegetables that they would consume through the week. That way, the children also get, exposed to something which is more healthier, and you're creating habits which can last a lifetime, which can go for generations. Menu planning, involve children in menu planning. In fact, I always tell parents on a Sunday, sit down with the children and see what they're going to, what would they like to have for breakfast, lunch, and dinner, because it's always a challenge for mothers that, what to cook every day. Cooking is not a challenge. What to cook is a bigger problem. So if we have the children's buy-in here, it becomes very, very easy to implement, because the ingredients are in the kitchen, and involve them in cooking. I think during COVID, a lot of children were at home and parents did involve them in cooking, but make that a practice, encourage them to make something healthy. And I think that can be a good activity, and you can even have a birthday party around it. Advanced glycation end products. And today we know that the modern diets, they're largely heat processed, and as a result contain high levels of advanced glycation end products. I'll give you a very, very simple example is of smoked almonds that we get on a flight. Everybody loves it, but that has got a very high amount of age. Therefore, raw almonds are better than your smoked almonds. So age is formed within the body, but it also exists in foods. and they are naturally present in uncooked animal derived foods. And cooking, I know today a lot of people, because they want to eat healthy, they say you must grill your meat or grill the chicken. But exposing the fat of the meat to a flame actually produces something what is called as pH, which is polycyclic aromatic hydrocarbons, which is actually carcinogenic, and therefore it also has higher amount of age. And therefore we have to look at more healthier options. So consumption of legumes, low fat milk products, vegetables, fruits, whole grains, fish, and reducing the intake of solid fats, fatty meats, full fat dairy products, and highly processed foods that are higher in age. Cooking methods such as poaching, steaming, stewing, and boiling are much better than the other processes. The use of acidic marinades such as lemon juice and vinegar before cooking, which has also been a traditional practice. We've been squeezing lime on food. We have been adding, vinegar to our fish curries. And again, we are reinforcing traditional Indian habits. And that's why we tell families now, go back, and especially families who live with their parents, I think they're really good, because then they're still continuing with some of the traditional healthy habits. Again, we have the Indianized version of the Mediterranean diet, which is really good. It is very similar to our Indian diet. In fact, AIIMS has rolled out the first Indian adapted Mediterranean diet to tackle heart disease crisis, and the trials are underway. Plant-based diets. If you look at Indians, we are predominantly plant-based. Even if we eat non-veg, we don't eat it on a regular basis. Again, you have different kinds of vegetarians. You have pescatarians who eat fish. You have vegetarians. Nowadays, you have vegan. But very importantly is to make sure that if they follow a vegan way of life, we have to look at nutritional deficiencies that could arise because of this diet. We have a lot of children today because of their parents who are following vegan diet. But there could be a risk of, one is protein deficiency, second is vitamin B12 deficiency, and iodine deficiency. And today you have a lot of families who are using pink salt. Now, pink salt may not be iodized, and therefore there could be an iodine deficiency that could arise because of this, especially if they're on vegan diets. So we're talking about healthy plant-based diets predominantly, not that you have to give up on non-veg, but again, all guidelines state that plant-based diets are more anti-inflammatory. Your processed meats, especially a salami, sausages, bacon, which a lot of people have, sugary drinks, refined grains, trans fats, are all pro-inflammatory. Now, snacking patterns. I'm sure you all will relate to this. Skipping meals and snacking is very common in adolescents. In fact, when we take dietary recalls, we're surprised that today dinners have been replaced by snacks. Nobody really eats dinners. They'll have a pani puri for dinner, they'll have a sandwich for dinner, they'll have bhel puri for dinner. Or, you have these Italian meals. There'll be pasta, pizza, bruschettas. This is all dinner, especially in the part of the country that I am from. We have a large Gujarati population which actually does not eat proper dinner. Most families, they've now started eating more of these snacky options, which could be made healthy, but most of them could be also high in HFSS. Again, snacking while watching TV, late night snacking, meals have been replaced by snacks, high fat, sugar, and salt foods, and ultra processed foods. And this is something that we found from our own study that we did with adolescents and young adults. Packaged fruit juices and ultra processed foods are perceived to be healthy, and adolescents who snacked in between meals had higher BMI and percentage body fat. Now, if you see, this is what most people snack on in the evening, either biscuits or it could be namkeen, or today, because you can order in, all this is very, very easily available, including your noodles. So they're high in carbohydrate, especially refined carbs, high in fat, especially trans fats, high in salt, sodium content, high in calories, highly processed, high in simple sugars, low in protein, low in fiber, and high in preservatives. And this is what the challenge is. Again, what we also see is healthy snacks. Availability is a challenge. Portions are very, very small, and affordability. For example, you look at makhana. We all promote makhana. But if you look at makhana cost, it is around 1400 rupees for 1000, for 1 kilo, which is really expensive. So when you're going to get a biscuit packet, say for 5 and 10 rupees, makhana is around 130 rupees a packet. So it is way, way too more expensive and not affordable by everyone. And therefore, again, another urge that we need to make to the government is to make healthy food more accessible, more affordable, and put taxes on the unhealthy foods, which is done in many other countries. Now, factors that hinder healthy snacking habits, availability of healthy snacks in small portions. And this is what came out from our study. lack of knowledge about interpreting food label information. Not all food labels are also accurate. Sometimes we see a lot of inaccuracy, which you can go and complain to FSSAI as well as ASCI. Healthy snacks more expensive, like we mentioned, and therefore we need to have more user-friendly food labeling, availability of healthy snacks in smaller portions at reasonable price. We need to promote this. And again, we're looking at healthy snacking options. So instead of all the unhealthy snacks, we again, as a country, we have a lot of our own traditional healthy snacks. It could be a simple unsalted peanut chana. It could be plain yogurt, because flavored yogurt will have more sugar. Sometimes even 3 to 4 teaspoons of sugar in a small cup of yogurt. Boiled eggs, very, very simple, easy to make, easily available. Chana chaat, you have unsalted nuts, and you have sukha bhel, known by different names in different parts of the country. And of course, there are many, many more. You can make a simple moong chilla, a besan chilla, if we have somebody making it at home. Again, very important is to get innovative with meals. Children, of course, will get bored if they're going to get roti sabzi every day or dal rice every day. We also have to make efforts. One is to make the food more visually appealing, make it more tasty. And today we have a lot of access, to YouTube, which shows us healthy recipes as well. We can tweak them, and we have a lot of options. In strawberry season, we can actually tell them what to make out of strawberries, and children really like to do this exercise. So get innovative with meals, look at ways to lower the carbs, improve the protein quantity and quality, lower the calories, and lower the amount of saturated fat and trans fats in the diet. So control all, delete all your HFSS foods. So one thing is no apps, especially when it comes to children. We've had mothers who've come and told us that the children have, on their app ordered food, but, no contact, in the sense the food is left at the security down of the building. The child goes down, eats the food, and comes up, and parents do not know. I've had a parent who actually told us they found packets of unhealthy food in the waste bin of the bathroom. So this is what happens. Children go to the bathroom and are eating unhealthy food, because that is a kind of addiction that has happened because of these foods. One is that we also need to make efforts to make healthy food available at home. Sometimes that's not there. So what do the children eat? They will always look at unhealthy food. Late night eating, sleeping, screen time is a big challenge. Teach them to read food labels. Again, when we're looking at sugar consumption, these are what the recommendations are by ICMR, NIN, and WHO. But our children are guzzling down all these, drinks. We have so many, and they sound so scary today. You have Predator, you have Monster, you have Red Bull, and a lot of our children are consuming this. And sometimes they have, say, 13 to 15 teaspoons of sugar in one can. And that can itself be so unhealthy. So again, making healthy options available. It can be a simple buttermilk to your sattu drink. It can be a, raw mango panna, which has got less sugar. It could be a cucumber buttermilk, a lemon juice, etc. Again, hydration. We often see that children are not hydrated well. They forget to drink water, or they do not know that they have to drink more water. So focus should be on drinking more water, especially sometimes if they're hungry, they could actually be more thirsty. Today, this is an excellent initiative that came out from the government and ICMR and NIN, when they're talking about having fat boards in school and sugar boards in school, educating the children and families on how much sugar is there in most of the foods that they consume. And I think this really brought a good kind of awareness, but we have to keep reinforcing this time and again. Doing events in schools. I think again, as healthcare professionals, we can actually go and educate schools and children about it. In fact, I remember talking to one school, and the mother actually called me up saying that, "Oh, you said this malted drink is not healthy. Is that true?" And I said, "Yes. This malted drink has all sugar. It does not have protein. It does not even have 1 gram of protein." And then mother said that my child refused to have it because you told her not to have it. And I was so touched and amazed. And I really felt that that visit to the school and that lecture in that school was so worthwhile. So small steps towards a fit Bharat by Government of India. I think this was a very, very good move where they're putting extra GST on certain foods, and we also looking at namkeens, etc. Gut microbiota, again, having a healthy gut microbiome. Again, if you look at traditionally, if you look at the eastern part of the country, we have Panta Bhata Pakala, which is a great probiotic. You have Ambadi down south. You have Gugruk, which is there up north. You have kanji, the beetroot kanji or the black carrot kanji. These are all natural probiotics. And be it any part of the country, I think we had our own prebiotics, probiotics. So we have to look at again, developing a healthy gut. But just popping in probiotic pills won't really be the solution, because if the gut environment is not healthy, in the sense, if the child is going to be consuming a lot of HFSS foods, a lot of sugar in the food, the gut environment itself is not healthy. So how are our good microbes going to grow there? So we have to look at, one is a good, gut environment, and then good gut, microbiome. Eating speed. The faster that the child eats, or the faster we eat, the higher is going to be our risk for all metabolic conditions. And therefore, slow eating, slow cooking is something that we look at. So counting your chew count is very, very important. So it's a cost-effective means for weight management. In fact, we just published a paper on this when we looked at just reducing the chew count, or the number of bites that the child or the person is eating. It actually helps in reducing weight. So this could be a good thing that we can look at. Put the food in the mouth, relish the food well, and then put the next morsel of food. That way, the person will achieve faster satiety and eat lesser. Chrononutrition. Today, I remember as a child, our kitchen used to be closed by 7:38. There was no food, access to food. Today we have our children eating at 1 o'clock and 2 o'clock in the morning, because today you can order in, or you can go to the kitchen and eat because you're watching TV late in the night. So again, eating, having proper meal timings, and this again has to be practiced by the entire family. Because if the parents are going to be eating at 10 and 11, how can we have our children eat early? So eating on time, sleeping on time, waking up early should be emphasized at every clinic visit. Early puberty is something that we are seeing, precocious puberty. So again, looking at all the endocrine disrupting compounds, educating them about it. Physical activity recommendations, I think Dr. Vandita has already spoken about it. So this is all the physical activity recommendations by the IAP. So school curriculum should also incorporate 30 minutes of exercise every day. We are looking at physical active, and we always tell parents, sometimes make it unstructured, because today what happens is parents are putting them from one class to another. Again, that becomes added pressure. I remember as a child, we used to go down and play with our friends, and we used to really. Today, parents tell us that the children go down to play, but they are on their phones. All the children are on their phones. So maybe they have to go down without their phones, or sometimes they're eating unhealthy and coming up. And increased need, which is non-exercise activity thermogenesis. Recommended sleep duration by age is again mentioned in the IAP guidelines: 0 to 5 years, at least 11 hours, 5 to 10 years, at least 10 hours, and 10 years and above, at least 9 hours. No screen time up to 2 years, maximum 1 hour from 1 to 5 years, 2 hours from 5 to 10 years, lesser the better, and balance screen time with other age-specific development goals. Today, our children sometimes, in COVID, they were exposed to a lot of screen, because that's how the learning happened. But we have to reduce on the screen time and encourage parents to be good role models. This is an excellent initiative again by FSSAI. In fact, I was a part of the Eat Right School movement. We did a lot of sessions during COVID, which were online sessions, and we had different schools engage with us. We have to look at improving the school canteen. We have to look at even outside the school. Sometimes the school canteen may serve healthy food, but outside the school, there's a lot of unhealthy school food available. Birthday parties, maybe, be good role models. Tell the parents to be good role models and serve healthier options when they are hosting a party. And that will have a ripple effect, and I think all parents will then follow suit. So take home message is prevention and management of obesity and in children and adolescents requires a multidisciplinary, multi-faith approach, regular follow-up and motivation. I think most important is follow-up and motivation. It has to be gradual, like, we agree. It has to be gradual, not drastic, sustainable weight loss. Practice mindful eating, slow eating speed, follow the 80-20 rule, no screens and gadgets, especially when eating, focus on portion control, nutrient-dense foods with diet diversity, ensure that there's enough family support. And this is very, very crucial. So having separate conversations with the parents becomes extremely important, because they need to change the entire family environment. Follow a predominantly plant-based diet, which is the IAMD, which is the Indian Adapted Mediterranean Diet, which is very similar to our Indian diet. Low dietary ages, physical activity at least 60 minutes daily, adequate sleep, and eat foods grown on plants and not manufactured in plants. And this is me. And I feel so blessed to be in this profession because I totally understand what it is to be there. I myself was an overweight, obese kid, teenager, and that really brought me into nutrition. And it's been 27 years of my journey as a nutritionist. And today I meet several kids and I understand what it is to be there. So empathy is very, very important. This is on YouTube. We have, started Food Facts Decoded because there's a lot of myths and misconceptions around food. So you can actually, click on these, scan these barcodes and you can access the videos. And this is my book, which is Diet and Diabetes Simplified. So thank you so much for your patient hearing. I'll be happy to take questions. I'll just stop sharing screen. Yeah.
Thank you so much, ma'am, for undertaking a wonderful session on all aspects of dietary aspects of obesity. Now I request our chairperson, Dr. Vipansal sir, for his comments.
I think she has very well explained. My one question is very good quality of carbohydrates. Like fructose is not a good carbohydrate, but fruits contains a lot of fructose, right? But in our country, we take fresh juices, so that is minus fibers. So how do you, comment on it?
So fruit is better than fruit juice. We do allow, say, 2 fruits a day is fine, which are spaced. We don't really recommend it with the food, but fruit by itself and seasonal local fruits is great. And I think God has, nature has so beautifully planned our fruits also. If you look at the winter time, we get vitamin C rich fruits. Because our immunity is lower. You come summers, you get a lot of water containing fruits, whether it's watermelon, muskmelon, ice apple, so every season, and you get mangoes. Again, mangoes are great for heartburn and acidity. So encourage them to have fruit rather than fruit juice, because when you're making a fruit juice, you use at least 4 to 5 fruits. Sometimes you add sugar, you strain it, so the fiber is all out. And definitely no packaged fruit juices because they will have a lot of other things as well as the high fructose corn syrup. So, but other fruit is fine. The only thing is
One thing more.
Yeah.
One is jaggery and honey is quite promoted because of good quality of carbohydrates. Is it true?
So jaggery, honey, sugar, brown sugar, it is all same in terms of carbohydrate.
Okay.
It's all the same, and it's a myth that jaggery is high in iron. In the olden days, we used to make jaggery in iron containers, and that's why it was called to be high in iron. Today, we don't make jaggery in iron containers, and typically people end up using more because it's jaggery or it's honey. We have to remember same calories, same carbs.
Okay, thank you.
Comments from our president, Professor Dr. G.S. Naran sir. Any comments or questions from you?
It was a very nice and elaborative talk. Many doubts cleared. Just now, the Dr. Ravi sir question, same question I had. We always advise our patients to leave the sugar and use jaggery. Very well explained that point. But in the villages, Dr. Ravi sir, villages, that jaggery and everything is made in iron pots only.
So that is fine, but the only thing is how much of jaggery, how much of iron will we get if we are going to tell them to reduce on the amount. Same thing happens with your pink salt, because people say use pink salt because it's got micronutrients. But how much salt we are going to use to get those micronutrients? I would rather get it from my, vegetables and fruits and other whole grains and pulses and cereals. So the whole idea is because typically people end up using more, and pink salt is less salty. So people actually end up using more salt. Unless it is more expensive, and secondly is that your sodium content is more or less the same. So you're not achieving any kind of reduction in terms of sodium, sir.
Normal small amounts can be used of jaggery.
Yes, absolutely. Jaggery is of course fine, and in small amounts it is perfectly. But if suppose somebody is making, people make cakes out of jaggery or desserts, and then they have it by the kilo because it's made from jaggery.
And what about many people? They are saying we are using dates as a sweetener.
The dates also is the same thing. It is higher in glycemic index. It has also got carbs and calories. So I would just say that, I love what FSSCI did. It says, aaj se thoda kam. So whatever you eat less. So whether it's dates or whether it is a sweet made with anything, eat less and use other grains. Like, for example, I made a cake yesterday, but I used natural sweetener. I used ripe banana and apple and oats. Again, I used whole grain oats, uh, not the instant oats, and that became very tasty. And that is something that we can educate. There was no fat at all. So I think we can give a lot of healthy recipes to our parents, which they can, implement at home.
Okay.
Actually, whenever we are using jaggery or dates, we are getting more nutrients and carbohydrate content is almost the same.
Yes, sir.
Like
Because
manganese and zinc you get from these. Dates are rich in iron also.
so, but if you're using maida and then putting dates, then the purpose is not solved, na, sir.
This is not good.
That's what it is. So
I
we have.
used to say it in Punjab, we have problem of drug menace chitta, which is called, you know what is chitta?
Sorry, I'm not able to hear you.
A drug,
White powder,
uh,
ma'am. White powder.
white powder, and
White powder or what?
so like you
The
can say it a
drugs.
heroin or smack, something like.
Drugs.
Yes. In Punjab, we have problem of chitta, and then we have same problem of chitta in children. We eat everything in white. Whatever you think you are eating white. You noodle, tikki, burger, pakoda, ice cream, momos, roadside champ. Ultimately, you are eating maida,
Right.
and with the no nutritional value.
That's it. Is
Then
that's the white
you
poisons of the heart.
I
Dr.
used
Cheryl,
to say my parents
at
that
one point,
that is
okay, can you suggest some alternative to the cakes, birthday cakes? Because this is the most usable items in the schools.
Yeah.
How should they?
One is that, we can definitely, I mean, they give cakes in school, is it?
On party, one kid brings and distribute among his or her
Yeah.
classmate. That's
See, there are healthier options. Like I was saying yesterday, I baked a cake and
fruit cake. We usually use fruit cake with fresh fruit.
yeah, we can give either fruit. Some schools actually, at least in Mumbai, they say, okay, you can just give apples to the children, or you
yeah,
can give
that's
something like that. In fact, I
that's
know a doctor who's now going to be the RSSDI president. He's president-elect right now. They never cut a cake for their birthday. It's always fruits. So we can do that, or we can. There are a lot of healthy recipes even for cakes that we can, but and once in a way, like even Dr. Vandana said, once in a way, if they're having it, then they might as well have the real thing and have less. So we have to educate them on portion control.
I want to continue same white, and I used to say my parents patients that shift from white to traffic light. Your plate should contain all the colors of traffic light. It means you are giving green, red, and or
Yeah.
all the dals, all the milk. And second thing is go from media to pedia.
Thank you, sir. Thank you
From
for your
media to
comments.
pedia, that will solve your problem with malnutrition of obesity. Obesity is the one of the malnutrition we came up big but deficient in all the nutrients.
Right, sir.
Thank you.
Ma'am, I have two questions. The market is these days flooded with that you drink this coffee, one particular brand, the weight loss coffee, or you take plant protein as a source of your protein, or certain, like, I don't want to name any brand, yoga bar protein powder is there. You make your, you can say, puddings or overnight oats soaked in those. So, what is your take on like all these market gimmicks, or these are just
One is, Dr. Seema, we have to look at the food label. In fact, every day there's something new. We constantly get pictures from our families and patients. So one is look at that. See, protein, if it's pea protein, one is that certain adolescents, when they take whey protein, they get a lot of pimples and acne. But if they are into, strength training, etc., and if they're not able to meet their protein, then if they require, then pea protein becomes a choice, or maybe vegans. If they are vegans, then that becomes a choice. But that has to be again chosen, and there are certain pea proteins which are available, which have got no artificial sweeteners. So we do recommend if indicated. And when you're talking about the next thing you asked me was for
these weight loss coffees
you
and
talked
all?
about coffee. See, MASLD, there is evidence to show that black coffee helps. But yeah, but again, how much of coffee, and especially coffee in the night, is not something we would recommend because that will interrupt the sleep. then your sleep is getting interrupted. That itself will cause, weight gain. So it has to be planned and if required and indicated. But for children, we wouldn't really recommend any of this. We would just go to regular home cooked meals because one is it becomes a habit. Suddenly that today everybody's popping in this and that. Every day we get one new thing. Should I take this? Should I take that? Also, you have to look at the cost. It is very expensive.
Okay.
That is why also the protein consumption in our poor country is poor, because if you look at protein foods, they are more expensive than your other foods. Cereals are more cheaper. Therefore, you see we consume more cereals.
Thank you so much, ma'am. Any other questions, comments? Dr. Monica, ma'am. She's our central IPB member. Ma'am, you're here.
Don't get
Monica, ma'am. Sir, conclude करें. Any other questions from your side?
We can conclude. It's
Sir,
already.
Ravi Bansal, sir, any other comments or questions want to take?
Dr. Dava is there.
Dr. Seema, black coffee is rich in iron.
Okay. Okay,
Black
sir.
chocolate.
I
Good
think the
evening,
issue is well taken on this particular day. It's a very much we have sensitized, and now it's our duty to sensitize the children of our areas, schools, IAP duties to sensitize our schools and to the parents also, so that we can get some result. Because at the end, the result is not there. You see, in 2004, the sale of packed food was 4,000 crore, right, in 2004. And in now in 2025, it is 5 lakh
26.
crore. 25 May, it's 5 lakh crore. It's rising very, very speedily. So we need to very strict action. Otherwise, this epidemic will. Yeah.
Sir, our theme for this year is 8 billion reason to act on obesity, on World Obesity Day. That was the theme. Okay. Dr. Adhava, sir, any questions or comment from your side?
Excellent effort. I just want to say that malnutrition ਸਾਡਾ ਪਿੱਛਾ ਨਹੀਂ ਛੱਡ ਰਹੀ ਪੀਜੀ ਵੇਲੇ ਅੰਡਰ ਨਿਊਟ੍ਰੀਸ਼ਨ ਸੀ ਪ੍ਰੈਕਟਿਸ ਵੇਲੇ ਓਵਰ ਨਿਊਟ੍ਰੀਸ਼ਨ ਹੈ maybe we are into private setup we see. So we stopped seeing those marasmic kids, kwashiorkor, and scurvy is almost obsolete. But the another problem, because with the obesity, I think the social problem, emotional problems, psychological issues, they are much more than we are anticipating. I think in coming times they may be increasing more. With after every Gushan, I have a request that as a state president, you always write a letter after every seminar which has of social importance to the health minister, copy to the chief minister. ਸਾਡੇ ਕੋਲ ਬਾਂਸਲ ਸਾਹਿਬ ਹੈਗੇ ਕਾਪੀ ਇਹਨਾਂ ਨੂੰ ਕਰ ਦਿਓ ਕਿਉਂਕਿ ਉਹਨਾਂ ਨੂੰ ਵੀ ਹੱਥ ਕਰਾ ਦੇਣਗੇ ਰੀਜ਼ਨ ਇਜ਼ that what government has to do regarding it. Though on paper things are existing that no fast food counter at least 50, I think 500 meter away ਤੋਂ ਹੁਣ ਘਟ ਕੇ 50 ਮੀਟਰ ਲੈ ਆਏ ਹੈਗੇ KFC ਵਾਲੇ ਹੈ ਨਾ that is a big lobby, I understand, but still I think education, right? I still remember the two-liner of famous Professor Janaki Raman of intensive care. He will always say assessment and reassessment at every point of time. One of the excellent BLS trainer I have ever seen said, you do something, then you assess and reassess. If the result is expected, you did a good job. If you failed in your mission, reassess, replan, redo, then again reassess.
Yes.
Have you reached the target? So assessment and reassessment, I think in every sphere of life, these two words will help everybody. Thank you. And I compliment the whole team for this excellent and much needed job.
Thank you so much. At the fagend of our webinar. I extend my heartfelt thank you to our speaker of the day, Dr. Vandana ma'am and Sheryl Salis ma'am, for taking the aspect of pediatric endocrinology, dietary management, prevention, how to stay healthy. And I also thank to all the senior dignitaries, participants, residents who spared their time on the afternoon and joined the session and made it a grand success. And this webinar will be available on our YouTube channel, Sapa. Please join and subscribe and share. Thank you. Thank you so much, everybody. Eat
Okay,
healthy, stay
thank you.
healthy, live healthy, stay active.
Thank you so
Thank you.
much.
Bye,
Thank you so
everyone.
much.
Bye.
Bye.
Bye bye.